السلام عليكم ورحمة الله وبركاته. اليوم إن شاء الله هنكمل فيديوهات الكدني ترانسبلانت بيزك كلينيكال بيرلس for general nephrologist and internal medicine. إن شاء الله احنا هنتكلم اليوم just نبذة كده مختصرة عن ال acute rejection as most common post kidney transplant but can happen at any time and does not mean graft loss. This rejection not means graft loss. This means like some inflammation, we need to deal with it. If it's, especially if it's acute, it can be cellular, T cell mediated, or humoral antibody mediated rejection, and it usually and should be done biopsy for diagnosis. And treatment depends on type of and severity of rejection. And we have already BAMF criteria for grading of this rejection. Reduction in acute rejection rate has not been matched with the similar improvement in graft survival. Acute rejection, as you can see, this lymphocytes infiltration here, and the tubulitis also. We can see the tubules already inflamed in betweens. This picture of acute T-cell mediated rejection, if you can see under microscope, this a typical picture of lymphocyte interstitial inflammation plus tubular inflammation by lymphocytes. This is a typical picture of acute T-cell mediated rejection, and with peritubular capillaritis and C4D deposition by immunofluorescence, as you can see, with in antibody-mediated rejection, as we can see this C4D staining in the peritubular capillaries under microscopy, either by immunofluorescence or immunohistochemistry. Also, this is a criteria for one of the criteria of diagnosis of antibody-mediated rejection, and we'll come to this in details with BAMF classification. As you can see, here's this interstitial inflammation again with tubular atrophy. As you can see, most of the tubules here atrophied here. Interstitial fibrosis and the tubular atrophy is like EFTA, is not clinic rejection, common histological result of variety of insult already, either donor-derived disease or ischemia reperfusion injury, immunological factor like rejection, recurrent disease, non-immunological factor, hypertension, diabetes, virus hazards. C9, maybe C9 also induces interstitial inflammation, tubular atrophy. Treatment include optimizing immunosuppression, keeping your immunosuppression around target, as according to your protocol in your centers, and managing hypertension, hyperlipidemia, diabetes, and manage any complication related to chronic CKD. Other common complication increase risk of cardiovascular disease, malignancy and infection, bone disease, especially with immunosuppression medication. Survival of transplant patients significantly better than dialysis, but still below the general population. Women can get pregnant and bear children after at least 1 year of kidney transplant if stabilized kidney function, blood pressure, and protein in urine. Graft loss, most common cause of death with functioning graft, cardiovascular death or stroke with functional graft, malignancy and infection, cardiovascular malignancy infection, cardiovascular malignancy infection. Return to dialysis or need for retransplant due to interstitial fibrosis, tubular atrophy, EFTA, chronic antibody-mediated rejection, recurrence of primary disease, acute rejection, acute kidney injury, polyoma virus nephropathy. We see this a lot, BK virus nephropathy after transplant from heavy immunosuppression. What the internist or general internal medicine need to know about the kidney transplant patient. Kidney transplant patient healthier than dialysis patient. Transplantation does not reverse pre-existence and organ damage or other disease. Is the best treatment but not cure. Most patients have some degree of chronic kidney disease relevant for drug dosing and a high risk of contrast-induced nephropathy. Common things are common, especially in stable long-term recipient may require longer course of antibiotic. Abdominal pain may be minimized due to immunosuppression, keep high index of suspicion. in transplant immunosuppressed patient in emergency or came by abdominal pain, don't take it lightly. You should take it seriously at some intra-abdominal problem, and you should do CT either with or without contrast, but be sure your patient got hydrated and stop all other nephrotoxic medications. Continuation of immunosuppression is necessary to prevent rejection even decades post-transplant. Always ask about adherence. Immunosuppression often does not need to be changed with mild, moderate infection. More likely to develop acute kidney injury than native kidneys. Transplanted kidney more sensitive to hypertension. Take care your patient euvolemic, little bit on hypervolemic side or hypertension side. Nephrology, renal transplant consultation can help in managing this patient. The renal patient or kidney transplant patient in emergency, common things are common, like UTI, pneumonia, CMV infection, gastroenteritis, especially with diarrhea, and the AKI, pre-renal, renal, and post-renal. You should put as a differential diagnosis for you. The common is common, just put these scenarios with you. The renal transplant patient in emergency also, immunosuppression is usually not changed in the setting of mild to moderate infection. Rising the creatinine is a very common and does not always imply rejection. You should put in your mind first, abdominal ultrasound should be requested if concerned about anatomical issue or obstruction. Things to keep in mind: time post-transplant, how long is this transplant, is recent, old, remote, whatever. Type of induction therapy, what is the induction basiliximab ATG, and what is the CMV and EBV status for your patient, is CMV mismatch or no, and what is the baseline creatinine for your patient. Serologies, as I mentioned for you, vaccination, your patient updated for his vaccine or no, for COVID and the flu vaccine yearly, and no live vaccine. Take with this in your mind. Post-transplant, no live vaccine. Ill contact with any relative or family, any recent rejection or change in immunosuppression, primary disease that can recur or no. You should look for what is the cause of industry renal disease, either it will be liable for recurrence or no, especially for GN. Also, UTI often lead to graft pyelonephritis. Usually, a patient came by typical symptomatic UTI, dysuria, fever, tender graft. Pneumonia, put in your mind, need broad and spectrum antibiotic, early transplant ID and respirology screening and the cultures. Diarrhea, often worsened by MMF, might need to reduce or hold for 48 hours, and don't forget to send for C. diff, Clostridium difficile, oviparasites, and norovirus and other enteric viral panels. Most patients will be admitted to the renal transplant nephrology service, except if acute cardiac event admitted under cardiology and nephrology or transplant team will follow up. Patient require non-transplant surgery. Patient may be sent to ER from clinic for admission if no bed available. If concern regarding management of the patient, contact your consultant on call. Severe stress, sepsis, acute coronary syndrome, major surgery. Hydrocortisone, 100 milligram IV every 8 hours. And once the patient is stable, change it to prednisone taper. Mild to moderate stress and complicated infection, with just 1 day surgery, just a triple straight dose for 3 days. If the patient can take per oral medication, just 1 prednisone equal 4 milligram hydrocortisone divided every 8 to 12 hours. 3 milligram cyclosporin can be converted to 1 milligram IV cyclosporin every 12 hours. And tacrolimus 0.05 milligram per kg per day. Continue IV infusion. 1 milligram MMF, same IV MMF 1 milligram. 1:1 MMF, and tacrolimus, as you can see, IV, and cyclosporin 3:1 from oral to IV. Remember also, immunosuppression breast patients have a reduced inflammatory response to infection and tissue damage, have a high degree of suspicion for occult infection, and order appropriate imaging. Don't delay in imaging because it's a kidney transplant. If they need CT with contrast, you should do CT with contrast. What's your approach to this patient? What is your differential diagnosis? What workup you will think? What is management and microbial immunosuppression and supportive therapy? You should ask yourself all this question when you present the case. If you admit this patient tonight, you should have differential diagnosis. What is your workup and what is your management? How would you approach this patient? Review just HLA typing, virology screening for CMV, ABV, and the recurrent of his primary disease, and TMA if any other suggesting lab or criterion from his examination, and de novo GN disease. General care of hospitalized transplant patient. The nephrotoxic agent should be avoided as much as possible. Avoid radiocontrast diet when possible. Pre-medication with still some centers use N-acetylcysteine and IV normal saline, just 1 ml per kg per hour, either for 6 hours or 6 hours 3 milligram per kg, or just give bolus or just give maintenance 12 hours before and 12 hours after. Just keep your patient on IV normal saline if his blood work is tolerated for normal saline, if no metabolic acidosis and no hypernatremia. Avoid any nephrotoxic medication, amide leukocyte and you can use just either cephalosporin instead if you suspect your patient with UTI or chest infection. And as regard the non-steroidal and ACE inhibitors should be prohibited after transplant, except if the patient stable after transplant by 1 or 3 months, you can use ACE or ARPs. Remember, again, immunosuppressed patients have reduced inflammatory response to infection and tissue damage. Just put in your mind high degree of suspicion any occult infection, especially patient came by abdominal pain, vague and clear. You should do appropriate screening for your patient. General care of hospitalized transplant patient who cannot take PO medication can receive some medication IV, as we mentioned this before. And acute renal failure, common causes within 1 to 2 months, either put in your mind the rejection, acute allograft pyelonephritis, CNI toxicity, hypovolemia, urine tract obstruction rule out by ultrasound, and CMV infection. Keep in your mind if you have just a CBC finding and liver function test finding and symptoms suggest just one patient just came by fever 38 and we did CMVs came high just from constitutional symptoms plus liver function plus CBC, you can suspect this patient CMV or no. Recurrent of primary kidney disease, focal segmental atypical HUS, more than 3 months, acute allograft pyelonephritis, hypovolemia, CNI, rejection, recurrence of primary disease, PK virus nephritis, post-transplant lymphoproliferative disorders, PTLD, especially if your patient ABV mismatch, donor positive, recipient negative, de novo renal disease. And this diagram causes of late allograft loss more than 1 year after transplantation, either this with functional graft around 50% of patient or chronic renal allograft dysfunction leading to graft failure in 50% of the cases, chronic allograft nephropathy in 30 to 40% of the cases, through chronic rejection, immunological injury, or chronic allograft nephropathy of mixed origin like non-specific interstitial fibrosis and tubular atrophy. We have other diagnoses, 10 to 20% of the cases, either from chronic toxic effect of CNI, other cases recurrent primary kidney disease or new de novo disease or acute rejection. Investigation history focus on medication change, adherence, history of CMV, ABV, mismatch, and recent illness or volume assessment. Physical examination focused on volume status. Lab including it should be just urine analysis, urine depth, and for urine sediment under microscope, serum C9 level, especially for tacrolimus, septic workup, and other radiology screening like transplant or Doppler ultrasound or CT as needed. Treatment, pulse steroid for patient with acute allograft rejection, and we'll come to this by special talk. Details. Usually we start in if suspect rejection, whatever T cell mediated rejection or antibody, by pulse steroid, and we can use, if confirmed, biopsy by T cell mediated rejection and not respond or resistance to steroid, we can use thymoglobulin. Don't forget the pre-medication for thymoglobulin like divinhydramine, Tylenol, or acetaminophen, and ensure ganciclovir or valganciclovir prophylaxis. And don't forget other prophylaxis for BGB pneumonia and fungal infection and PPI, and calcium, vitamin D, and because it's high dose steroid already. And reason for rejection should be addressed: inadequate immunosuppression, decrease C9 level, non-adherence, drug interaction with immunosuppression. But just put this in your mind: antibody-mediated acute rejection, either de novo DSA or pathological. Feature include C4D or other findings such as TME, peritubular capillaritis. In addition to thymoglobulin, will require additional therapies with plasmapheresis, IVIG, and rituximab. And we'll come to special video by special talk about rejection post-transplant. Causes of graft loss, as we mentioned before, to remind you, this of recipient was functional graft, cardiovascular event, infection, malignancy. This is the three common cause of death of recipient with functional graft. The other cause of graft loss, rejection, either from adherence or chronic antibody-mediated rejection. And the third cause of graft loss, recurrent primary kidney disease like glomerulonephritis. Summary and conclusion: risk of kidney transplant based on patient donor transplant characteristics, time dependent consideration, short term outcome of kidney transplant, excellent but less gains, a long term outcome. Quality of life clearly superior with transplant. Specific patient subset may benefit from kidneys from more marginal kidneys. Donor donation after circulatory death is an important source of kidneys with good long-term outcome. What is internists need to know about the renal transplant? Again, I am just repeating and finalize. Healthier than dialysis patient. Most patients have some degree of chronic kidney disease relevant for drug dosing. You should make drug dosing for this any new medication you will prescribe. And high risk for contrast-induced nephropathy, try to avoid as possible. Common things are common, especially in stable long-term recipient, may require longer course of antibiotic. Abdominal pain may be minimized to immunosuppression. Keep the high risk of index of suspicion if this patient came by feeling unwell or illness in emergency. Continuation of immunosuppression is necessary to prevent rejection, even indicates post-transplant. Always ask about adherence. Immunosuppression often does not need to be changed with mild to moderate infection. More likely to develop acute kidney injury than native kidney. Transplant kidney are more sensitive to effective arterial blood volume depletion or hypotension or hypovolemia. Nephrology, renal transplant consultation can help in managing this recipient. And thank you so much. And أسف على الإطالة، ونلقاكم بفيديو قريب بإذن الله. والسلام عليكم ورحمة الله وبركاته.